I'm going to talk about the critical care transport team in what we consider the ideal time-sensitive emergency. And I had the chance to help design this. And over the last decade or so, Damon Kradovic is here in the audience. He's been spearheading our efforts in being director of our critical care transport program. And let me show you what we've achieved over the years and what led us to design it the way we did. So if you're a cardiologist, you're comfortable with this slide because in the late 1990s, after doing a number of clinical trials, we'd pretty much come to the conclusion that primary angioplasty was superior to fibrinolysis in acute myocardial infarction. That being said, we still had to struggle with actually delivering that superior treatment to people in a 300 million country that's as big as ours. And so in the next decade, we as cardiologists created STEMI networks that has led to a systemization of care with ST elevation acute myocardial infarction. And everybody here realizes that the door-to-balloon time has become so good around the country that we no longer look at it as a quality indicator because it no longer represents real improvement in times. But when we started off, it wasn't that simple. This is the United States back in the turn of the century. We were making a choice, fibrinolysis or reperfusion, and we came to the conclusion, as you can see in this map, 80% of the United States lived within 60 minutes of a PCI hospital, and over 40% had a PCI institution as their nearest facility. But if they drove past this hospital that didn't have PCI, even a larger population had access to primary PCI. And so we came to create algorithms where we said, let's draw some markers here. If you are anywhere in the US and you have chest pain, we want the ambulance to come to you within 10 minutes and get an EKG done. If you're in an ambulance and you have a PCI-capable hospital or a non-PCI-capable hospital, we want you to drive to a PCI-capable hospital. If you come to a non-PCI-capable hospital, we want you to be transferred out of that non-PCI hospital within 30 minutes to get primary PCI. And as a result of having systems like this, we've really been successful as a nation in delivering optimal STEMI care. Now, can we apply that information to what we're talking about today? That's creating acute aortic system networks. And it's a little different because unlike ST elevation MI, where you have like 300,000 infarcts in this country, the number of type A dissections are probably 3,000 to 5,000. As Dr. Borden said, if you're an emergency room physician, you might see one a year. Unlike having the diagnostic EKG, where even an emergency room and as an outpatient in the ambulance, you go an EKG and you see ST elevation, we really don't have a definitive marker for diagnosis with type A dissection, and the CT scan has now become the definitive marker in the ER. We still struggle with a biomarker, and so it's not like someone's coming with an occluded circumflex and a normal EKG, and the troponin is alerting the ED to say, wow, you're missing an infarct here. In this case, all the ED has is clinical suspicion. The diagnosis site for a STEMI can be at home or in the emergency room. In acute aortic syndrome, it has to be in an emergency room somewhere. We have guidelines on time to treatment in STEMI. We know we want to do it sooner than later in an acute aortic syndrome, but that time dependence is a little unclear. And then while we have a PCI hospital in most communities, we will see in the course of this program that the number of places that really do type A dissection and do it well are few and far between. And so when you design an acute aortic network, unlike a STEMI network, your range is going to be much larger than for a small area for a STEMI network. Let me define that for you. This is our early STEMI network, shown in green, are hospitals where if you come in with a STEMI, like Dr. Borden said, an ED physician punches pound 64, and ST elevation is activated, they come to a cath lab, whether they're having an infarct or not. You meet them in the cath lab and decide whether you're going to open up that artery. The furthest hospital for that is 58 miles away in Ashtabula, but we can deliver optimal care with that setting. When you design a acute aortic network, you have the luxury there of not being bound to that time dependence. So when we designed our network, we thought we'd cover a much larger area than that STEMI network. It encompasses large parts of our surrounding states that we find. And so we did this around 2006, 2007, and as you can see, led by Damon Kralovic, we set up a system where if you call this line, what you get is a helicopter or some transport moving towards you and a friendly voice saying, how can I help you? Your transfer to the Cleveland Clinic is on its way. And we use that for 4 time-sensitive emergencies, as Dr. Borden said. And I must say, this is not misused at all. This is used only for these specific conditions and really helps folks. So the way the system was set was you call this number up if you're in an outside ED. There's transport going towards you. And on that transport, we have nurse practitioners and critical care providers who can actually provide active management during that transfer to our CICU. And then, of course, you come into the CCU, we make a decision what's going on, and we give you definitive repair. All the while, you have contact with our coronary ICU for any advice that you might need during that support. So here's our first 263 patients that we reported on back in 2012. These are 263 consecutive patients with an acute aortic syndrome who all get activated in this fashion. 104 end up having a type A dissection, 131 have a type B dissection, and you can see we created a new disease, false positive activation for type A dissection, which was not small because we'll talk a little bit about it, and then they go on to get definitive treatment. The transfer mortality was 0%, suggesting that you can safely transfer acute aortic syndrome through this large area. Along the way, I think this is what is remarkable, is that these nurse practitioners and critical care providers in a small helicopter ended up putting 61% radial artery lines, put 30% of the folks, they put a peripheral venous line, and about 4 or 5 of them needed intubation. They got intubated en route, and along with administering blood pressure medicines along the way. And you can see that even in that short 40, 45-minute ride into the CCU from where they were picked up, there was a significant improvement in blood pressure because of active management during that process. This is what Dr. Borden's talk highlights. Unlike that small STEMI network, when you take a look at where did these 300-odd patients come from, they actually came from 84 different emergency rooms at a median distance of 40 miles from here. You can see in most emergency rooms, the number are 1, 2, 3 MI, so dissection. So you really can't have the ED person have those same kind of triggers like a STEMI because they're not going to see it. The STEMI, they're going to consider it every day, and they're going to see one every week. For dissection, this is just something that's going to happen, and it may not happen to you for a couple of years. What we did do was consistent with the door to balloon time, we thought it was important to really measure our metrics of transfer. So these are the total transfer times of patients once that phone call is activated. This is the transfer time taken for a helicopter or a road transport to pick up this patient and actually for that patient to come back to reach our CCU. And you can see it ranges all the way from less than 60 minutes to 180 minutes, depending on the duration of that transfer. What we tended to measure was things that just made us better. So this is the handover time. We define handover time as when our ED folk, when our critical care transport people actually reach a community hospital, how long does it take for them to pick up that dissection or suspected dissection patient, put them back in the helicopter and come back to us? You can see those numbers vary significantly. It's important to measure this because all of you know the last thing you have is a guy comes back with a dissection, they forgot to bring the imaging. When you go in there, they haven't even started someone on a blood pressure medicine, there's no IV line. So really, when you measure these numbers, it's when you can drive, similar to our STEMI experience, excellence in terms of bringing people really quickly back to our home CCU for definitive care. So in the interest of time, I think a critical care network for aortic syndrome depends on your ability to bring people safely to a place for definitive treatment from a large hinterland. It's certainly something you can do because we've learned from a STEMI network, it's just a little different in terms of its range and its goals. Once you do that, transferring patients is quite safe. It doesn't have to be a passive transfer. You can actually do things along the way that improve the ability of the parameters in your patients. And certainly, we look forward to sharing that experience if anyone wants to talk to us about it in the break time. Thanks.